leads me to a question. I wondered, with results like that, do you think that in the future it will be likely that the go-to methods will be therapy mixed with psychedelics rather than the other like chemicals that we give, like nicotine patches, or for instance, with anxiety and depression, anxiety medications and depression antidepressants can have a lot of consequences, and you know, they aren't necessarily the best for your health with side effects. So I was wondering if you think that that psilocybin potentially could replace those, or in most cases replace them in the future.
So my guess would be this is never going to be a first line treatment. So usually the first line treatment is they kind of start you with what they think will work and is the easiest. And so kind of a low bar for entry, for instance, would be something like for quitting smoking, we'll be starting on patches. Reason being that there's very low risk involved, and also as a result, you can get it pretty much anywhere. Go to the corner store, the Walgreens or wherever, you pick up your cigarettes, and you can also instead buy patches. You don't need a doctor's orders, and they're pretty simple to follow. You just put one on every day like a Band-Aid, and you stop, on a quit day, and then you work your way down the dosing ladder until you're off. And so because that takes minimal intervention and is relatively safe, I think those types of things will remain first-line treatments. Same with medications. I think they're going to stay pretty commonly kind of prescribed as something that will, your doctor's going to give you if you come in complaining about an anxiety or a depressed mood problem. However, for people who, struggle after getting, a few medications and are not able to, get the goals that they're wanting, at that point, that's when you do need to explore other options. And so for, something like smoking cessation, addiction treatments in general, or for depression, then you might move to one of these more labor-intensive, time-intensive second-line treatments. Because if you can just take a pill and you don't have bad side effects, then that's quicker and easier than having to go through all this counseling and do these high-dose sessions, which do involve some risk. And so then those people can be taken care of with their first-line treatments, and the people who still need more help, will then hopefully be able to access, medical psilocybin as a treatment option then for whatever, whatever that might be, mood disorders or something like that.
I see. Thank you. So you imagine the future where it will be more used for people, for instance, who have been smokers for years and have had no success with other methods, and so they'll try psychedelics as an intervention rather than being a first line or anything like that.
Yes, and a really good example of that is in 2019, FDA approved Spravato, which is S-ketamine. It's basically a ketamine-based molecule that's been put into a little intranasal formulation, little spray bottle, and because it does have some dissociative types of effects, the way that S-ketamine is administered is you have to go to a particular place that's approved to administer it. Then you have to take it there and stay there for at least 2 hours. There's going to be personnel there who are monitoring you and looking for symptoms like blood pressure, or spikes, or changes in consciousness, which are pretty common when people are being dosed. And then once those acute symptoms subside, people are then generally let go into the into the real world and go back to their lives. And in order to get your insurance to approve Spravato for depression, then you have to have some documentation that you've tried a couple of these other standard pharmacotherapies. They have not been successful, and then they say, okay, we'll let you try this because, as you said, it's more time intensive, it requires more medical supervision, somewhat riskier, and therefore it's not considered a first line.
I see. Now, what if I could ask a follow-up question, what sort of environment do they have them in, for instance, in the ketamine trials or in your psilocybin studies that you've been leading, when the person is under the effects? Is it like a typical laboratory environment, or are they in more of a relaxed environment?
So with esketamine, there's not really much of a standard of care yet. As I understand it, they could just kind of stick you in a hospital room with an easy chair, and they'll have somebody, watching you to make sure you don't, get up and stumble out into traffic or something. And so in terms of what the setting is, it's kind of up to the providers, to come up with that. And I haven't seen too much literature about it, though we are working on a new trial now to test that out and see what setting kind of adds to the mix for esketamine treatment.
Wow.
But for our psilocybin sessions, this has been something that goes back to that earlier era of research in the 1960s, where they talked about set and setting as being big influencers of drug effects, and specifically the set being the person's mindset coming into treatment, and the setting being the environment in which it's administered. And for that type of work with high dose psychedelic administration, the early work and more the contemporary work as well has suggested that being in a comfortable environment that's aesthetically pleasing, as opposed to something like a hospital room with fluorescent lighting or in an MRI scanner, tends to have better outcomes. And so all of our session rooms here, which we just had a nice renovation and now have 4 rooms so we can run 4 sessions at the same time. They're all outfitted like a therapist's office. It's like more living room like, and have a nice couch, a couple of chairs for the monitors or the people who are sitting and watching sessions. And usually people are laying down on the couch for most of the drug effects, so that they don't stand up and get wobbly. They usually have their eyes covered and have headphones on or listening to headphones. And an interesting paper I was just reading this morning, actually, from the group at Imperial College London, was showing that when you get this change in brain dynamics and brain activity, they're looking at just eyes closed versus eyes open listening to music versus eyes open looking at a video. And they're actually seeing that with eyes closed, you're getting more of this change in the functional connectivity of the brain than when you're watching the video. And the idea is that perhaps when people are engaged with something like a video, it might keep them more in their sort of normal state of consciousness, whereas when their eyes are closed, and they're able to kind of get more absorbed in the experience. So that's why we've been using this type of almost sensory deprivation type setting with the eyes closed and laying on the couch, and very minimal interaction. So, the focus is not on having a conversation with the sitters or anything like that, but really kind of going inside and seeing what's going on internally in the experience.
I would hope that, and that makes me really happy to hear, because when you described the ketamine administration, it sounded very like it would be very alien almost to be in a hospital setting with the lighting, or maybe a very uncomfortable seat and doctors everywhere and lab coats and stuff. I feel like that wouldn't be very conducive to a positive experience. Whereas in the way you described it, the psilocybin studies, it seems like it's more relaxed and they could be more capable of being comfortable. And I feel like that would be more conducive to just a positive experience, psychologically speaking.
Yeah, and we're trying to test that out now at one of the Hopkins esketamine clinics. We're trying to randomly assign people to either get counseling in kind of a nicer environment with their esketamine, or just give it to them the way that the manufacturers say. Put them in an easy chair, give them the spray, make sure they don't get it, take off pretty much, and see if you get better antidepressant effects, which I hypothesize that we will.